All right, welcome everybody. I'm going to allow the people to come in as it's building up. So hello and welcome. My name is Jada Shapiro and I'm the founder of Boober. Boober is where expectant and new parents can find all of their pregnancy and postpartum care providers. And especially in this really intense time as we're dealing with the coronavirus, we have all virtual care for people. So at Boober, you can find a lactation consultant who can do remote visits. You can find a birth doula, which is especially important right now, as we're going to talk about in a little while, that birth doulas and partners in some hospitals are now not being allowed into the labor room. And so we think virtual doula support is so critical right now. We can support you with postpartum care virtually. And also this week, due to all of what has been happening with COVID-19, we decided to fast track and launch the mental health virtual therapy services with licensed mental health therapists who specifically work and specialize in pregnancy to postpartum. So that is a little bit about myself and Boober, and we're so glad you have come today to learn from two amazing experts who are here. We have Dr. Jaqueline Worth and Dr. Julie Capiola here, and Dr. Jaqueline Worth is an OBGYN who I have worked with for many, many years, and I'll just read a little bit quickly about her. She's been in practice for nearly 20 years, has delivered thousands of babies. Her practice is dedicated to work with women to achieve a safe birth that meets their individual needs. Dr. Worth is a co-founder and co-physician at Village Obstetrics and at Village Midwifery, which is a collaborative physician midwife practice in downtown Manhattan and soon coming to Park Slope, Brooklyn. She's the proud mother of two young women, lives in New York City, spends much of her time delivering babies and witnessing the miracle of life at Mount Sinai Hospital. And she is the co-author of The New Rules of Pregnancy. So we're really happy to have you here, Dr. Worth. And let me just tell you about Dr. Julie Capiola, who is a pediatrician and an IBCLC International Board Certified Lactation Consultant. Dr. Julie Capiola completed her residency at Yale New Haven Hospital, where she was awarded the prestigious Morris Krosnick MD Award, which is an award given annually to the senior resident who best exemplifies the qualities of caring, compassion, dedication, and the pediatrician with whom you'd most like to take care of your own children. She has been in practice for 12 years at Premier Pediatrics, which she is a partner at Premier Pediatrics, which also launched the first month, taking care of all of the wellness and care support needs of parents as they transition into postpartum. And I'm going to allow you both to say hello, and then we'll get started. So, Dr. Worth.
Oh, hello. Thank you, Jada, so much for having us back. What a week it's been. You know, we can only begin to wrap our minds around what's happening, but however we can help, we're here to help.
Thank you. And Dr. Capiola.
Thank you so much, Jada, for having us again. We look forward to hopefully repeating some of the information and also giving you some updates as to things that have changed over the last week.
That's wonderful. Thank you. We have so many questions, and I think we will repeat. We did our webinar last week, part 1. Today is part 2. So let's start. I want to ask Dr. Worth today. We heard some big news that one of the hospitals in New York City is not going to be allowing fathers or partners in the labor room as of today. We had expected that to be coming. We'd heard that had happened in other cities. In some hospitals, we know that doulas, as of a week ago and some days ago in many hospitals, have not been allowed. So we would love to hear if that is true, if you've heard that's true, that partners, fathers will not be allowed into the delivery room. And if so, another big question we have out here is, what are the hospitals doing, if anything, to help the people have virtual support? We really know that having support through your birth is so important. And as doulas at Boober, we're all providing virtual doula support. But if the partners and fathers can't come in, is there going to be some way that we can help them get connected, have a laptop open, some way to have the partners to be there for part of the experience? I would just love to hear your thoughts on all of that that's going on right now.
Yes. Thanks for bringing that up. I mean, I too heard this a few hours ago, actually, and it's obviously shocking and big news and, you know, going to be really difficult. And I think we just have to accept this news in the context of this public health emergency and trust that our hospitals and our experts are doing everything they can to protect us, and that, you know, this is just, you know, big and hard. There's nothing else to say. So So far, this is not true at my hospital. At my hospital, my hospital has a no visitor policy with an exception of end of life, maternity, and a child, where one designated person who does not switch can come with that person. So I think we just have to see. But what can I say? We're going to have to figure this out together. I have been working all week with talking with my doula friends about how to have their work be virtual and be effective. I can talk a little bit later about some techniques they have, but I think we just have to stick this out together.
Yeah, thank you so much. And we appreciate hearing, day by day, this is getting updated at each hospital. So everybody out there probably wants to check in with their own hospital, their own care provider to see what the policy is on a given day. But I know, Dr. Worth, your practice is extremely doula friendly. And we really appreciate that you feel that support is important. Can you speak to that a little bit? Because I think people don't realize that there's such a thing as virtual doula care that's been around actually for as long as the technology has existed, but it hasn't been used in a wide way. And right now, at Boober and everywhere else, all the amazing doulas of the city are coming together and trying to figure out how best to offer virtual care to people. So can you tell me a little bit about working with doulas and where you find them to be useful?
Sure, absolutely. I think we need to pause and just remember that some of the public health guidance right now is that we really should not be in contact with other people. We should minimize our contact with other people. So if we truly going forward are not going to be in contact with any other people, then some of what I say may not apply, which is that until, this weekend, I was suggesting to my patients that they continue. We have about a 95% doula usage rate in my practice. Almost all of our patients use doulas. And I strongly support that and find it to be tremendously helpful. And so what I had suggested, really until this weekend, was to continue to work with your doula in early labor as you would have before. Your doula might talk with you, come to your home, help you, go through some of the early labor components, and then help you get to the hospital. And then at the point that you move into the hospital, potentially convert to being virtual. And so I was speaking with a doula friend yesterday. She said that it's been working well for her she showed me a flexible arm that holds a cell phone. She found this to be better than the laptop, where she could actually clip it on the bed and sort of be there, where you could move this around to sort of see what the patient was seeing, and then switch it around so the patient could see the phone, and she could demonstrate different techniques about how to continue on in labor. And this is a doula that I've known for about 20 years. And she said that this sort of attaching the cell phone with her on it to the bed and moving it to participate in what was going on was very helpful for the patient and her husband. So I think that's what she emailed me the Amazon device. It's about $20, and I was going to show that to patients and have them buy that. I'm still trying to think about how we could do this without the husband, but oh my goodness.
Right. Yeah. And that's something I've been thinking about too. If we know that OBs and nurses and whoever is on the staff could just help to do whatever that is occasionally when clinically there's a moment that it's possible. Right. So we'll think about that, but also know people out there that even if you don't have the virtual kind of interactive video support, even being able to call a doula periodically and ask questions and talk and just hear their voice and get their suggestions can be super helpful.
Let me add, the 2 births that I have done since last week, we had 2 labors this week. Neither patient, even though they had doulas, called them while they were in labor. So I think it's a little bit of a work in progress. Not that they didn't want to, but it just somehow didn't fit into what we were doing. And so I think it's something to think about.
Yeah, definitely. And I think, as we always teach in all of this, is that we have to be flexible throughout labor. However it's going down, we never know what's going to happen. And somebody's asking for the link for the virtual. I was seeing that question. We've heard that we really want to limit the amount of time we spend in a hospital right now. So my next question for you, Dr. Worth, is, are you telling people who are in labor to stay at home as absolutely long as possible if clinically, if that's medically well, if that's suggested? Are you sending people home early? We know that typically people in the US get discharged, 24 to 48 hours after a vaginal birth and 72 hours or more after cesarean birth. What is the plan right now in terms of discharge, and what are you telling people in terms of coming?
Sure. So I'll start with discharge. That's the easier part.
Okay,
So,
great.
my hospital has advised us to try whenever possible, effective immediately, to have vaginal birth patients go home on postpartum day 1 instead of postpartum day 2, and C-section patients to go home on post-op day 2 instead of post-op day 3. And so that's what I have been doing in the past week. There was a question of whether a patient could go home earlier than 24 hours. And it mainly relates to whether or not, when a patient goes home, I discharge the mom and the pediatrician discharges the baby. And so we can ask Dr. Capiola about this. And so at my hospital, babies are not discharged until 24 hours of life. When I raised this question with the director of OB, she said they were actively investigating, protocols, policies, safety measures to allow the babies to go home earlier. I have not yet heard anything about that, but we have a command center call with all the doctors tomorrow morning at 7:30, so they may be updating us. That's how we're now learning of these things. We have these, large scale phone calls.
Right. Well, thank you. That's really, and actually I'd like to shift that to Dr. Capiola for a moment, because we know typically when we used to have people who would be, say, in the birthing centers who had early release, and they would leave maybe 6 to 12 hours after they gave birth, if all was well, we had the issue of having to get the PKU test within 24 hours. And so they would have to go to a pediatrician visit on their own or have a home visit if that was something possible. So I guess I'm wondering, if we are releasing OB patients early from the hospital, what is the plan in terms of getting the necessary testing done for the babies after?
So first, we have to make sure that the baby is medically clear for a number of other reasons. Some babies are at increased risk of things like jaundice, and those babies may need to be monitored longer. But if the baby is medically clear and they need to be discharged prior to 24 hours of life, then 2 things do need to be done after leaving the hospital, and they need to be done within a fairly timely fashion. And the first is in New York State, the New York State newborn screen, which is a blood test that looks for a number of different conditions for which an early intervention is life-saving, potentially. And so our practice, for example, is going to arrange for the newborn screen to be done in our office within 72 hours so that those patients can be safely discharged if they are medically clear to do so. That's important. And then also there's usually a congenital heart disease test that's done before babies leave the hospital, and that's done after 24 hours of life as well. That can also be done in the pediatrician's office. It's usually just a simple pulse oximetry. So that would be done potentially there as well. So that's what we're arranging for our patients.
Okay. Dr. Capiola, do you feel that most pediatrician offices have that capability?
Pulse oximetry is fairly standard, so I would certainly ask the question. We have our nurses trained to do the newborn screen. Potentially some pediatricians are able to do so. So I don't know about everyone, but many may. I would certainly reach out and ask, though. That's a good question, Dr. Worth.
What if there is a situation where the baby actually is admitted into the NICU and is not able to leave? Are we typically here? We do often discharge the new parents without their baby sometimes, but in this case, they often are able to visit back and forth. Do you actually know any of the protocols that are being put in place if a baby is in the NICU?
That's a good question. Actually, I'm not aware. I don't know how much it's come up yet either this week with everything ever changing.
Just starting.
What do you mean? You mean, I'm not understanding the question.
Like if the parent gets discharged, the baby is still in the NICU, and normally parents can come and go and come back and forth and see their baby. Do we know, you're in the hospital, Dr. Worth, do we know any of the protocols that have been updated as per the NICU at the moment?
It's a very good question. I have not seen that, but it probably, if it's only one visitor for a child, it would probably, I would imagine, at my hospital, it would be one parent would be able to come and go as the one designated visitor to that child.
Okay.
But I have not seen anything about that.
We will update out on that for sure as we start to learn what is going on with that. So question for Dr. Worth, how are we dealing, a lot of people asked, how are you dealing with non-essential people coming into the labor room at this point? I know that as a doula, when I've been in the hospital in past days, you know, there's people coming in who are taking care of the room, changing the trash cans, maybe running in to get an extra item for a different room. You might sometimes see 10, 12 people who would breeze through. Are there any new protocols to try and limit the people, especially as we're limiting partners and doulas and essential support people like that?
Well, everyone on the labor floor is now working in teams, so that people are, it's a set team that's working for a day, for 3 days in a row, and then a new team comes on so that there's minimal exposure of that team to the outside people coming in and out. I mean, I think the part of all of this is the necessity to keep staff healthy. And so staff, as they're coming in every day, are screened to make sure everyone is healthy. And there will be very minimal people in and out of the rooms. I mean, there's not much of a reason to go in and out of the rooms.
Okay, great. And is there any, people have asked, is there any new protocol in terms of sanitizing the rooms between patients? Anything different that we're doing? People want to know.
Well, if a mom is COVID positive, which I have not yet encountered, there is a deep cleaning, an extra deep cleaning protocol, I believe. You know, I just know what I read, right? So I believe there's an extra deep cleaning protocol for the rooms. And I'm sure that there's just cleaning going on constantly in the hospital.
Yeah. And with social distancing now firmly mandated, actually we're about to see tonight at 8 o'clock, at least in New York State, the mandates go into effect. We talked last week a little bit about prenatal visits and appointments, and we talked about different things that you were sending home with your patients so that you could minimize some of the prenatal visits. And then the question came up, so I guess I would like to hear how you're dealing with prenatal visits this week as time goes on. And one of the things you said that you couldn't do at home was use a Doppler to monitor your own baby. And I was wondering, has that protocol changed at all? Are you encouraging people at all to monitor themselves and their baby? What are we looking at this week?
Sure. Great question. So, you know, along with social distancing, it has been recommended that all non-essential, that you assess whether visits are essential, and so that you potentially, as a physician, spread out the prenatal visits, decrease, eliminate things that are not necessary. And I can go into the details of some of that. And so what I've done in my practice and what I've seen other doctors do is starting to introduce telemedicine. And so I started, I believe Friday of last week even, I mean, we've just barely started this, offering any patient who didn't feel safe to come to the office to do her visit by telemedicine. And as part of that, I'm recommending that my patients have a blood pressure cuff and a scale. I'm sending them the urine dipsticks, and then I'm speaking with them through Zoom and going through their, they're telling me that they're quote unquote vital signs. And then I'm going through the issues that would come up at that visit. I have a sort of a curriculum that I go through. So at each visit, I have certain things that I talk about. And so I'm continuing to both do that, address their concerns, and review their test results with them. And I sort of outlined for my practice essentially an alternating, where you would do a live visit and then a virtual visit, but that was just a suggestion. I think we're just individualizing. Anybody who doesn't feel safe to come to the office, and I'm going to help them do the visit remotely, and then help them determine on a case-by-case basis when they need to come in.
And then in terms of the Doppler.
And then, so then in terms of so obviously the last piece of that is checking the fetal heart rate, because that's a critical part of the visit. And, checking fetal movements is a substitute, but it's not a full substitute for checking the heart rate. So we talk about how if it's a remote visit, you can't check the heart rate, but I'm having my patients, pay close attention to the fetal movements and use that as a surrogate for a healthy fetal status.
Okay, thank you. And we also talked back into minimizing our time in the hospital. We talked a little bit last week about induction, and that people had questions. Should I be induced before, there's a real concern right now about the amount of hospital beds. Are we gonna, especially in New York, as we're about to see this surge is starting to happen. People are concerned, and so they're asking again, should I be induced? And last week we didn't actually even talk about this, but some people have had the question, should I schedule a cesarean birth? Any of those, I'd love to have you address induction and cesarean again, because I think especially induction, that was important what you said, and we have some new people here.
Sure, absolutely. I think this is a question that changes a little bit based on where we are in this pandemic. So right now, for somebody who is 38 weeks pregnant, let's say, who sort of is asking the question, should I ask my doctor for a labor induction, which would be done the earliest generally is 39 weeks, or should I wait to see if I'm going to go into labor? So I think that the things that she and her partner might want to consider is, with the concern with each passing day that the disease is getting worse and that you're more likely to be exposed to people in the community, I do think it's a reasonable question to say, maybe I should just get this done with. I should ask my doctor to induce my labor, and get this over and then move out of town or whatever it is we're all going to do. So that's one thing to think about. Induction of labor does almost always expose a patient to a longer time in the hospital in the labor phase. So if you want to minimize your exposure to the hospital, induction of labor for a first birth on average takes about 20 hours, and it may even take longer. So, and spontaneous labor, when you come in, your labor starts at home and you come in relatively active, it's unusual for that to take 20 hours. So those are the things that you're going to need to weigh as you individualize this decision. And then C-section, that's a whole nother matter. There is no question that C-section is, unless you come in very active, the fastest way to give birth, although then you're exposed to a longer recovery. I do believe in China, many of the babies were born by C-section, but that is, I think, more common in China than it is here.
Okay. Thank you. And I think, as time goes on, people still have some of the same questions as last week. And does a week give us more information about anything in terms of pregnant people passing, any issues with passing the coronavirus to the baby? That question is still coming up for people. And is there any more information on that?
Sure. So in preparation, I was reviewing some of the information from the Royal College of OBGYN in England. And I'll send you the link, actually, which was updated as of March 21st, they very clearly state there that there is no evidence of any increase in miscarriage rates, no evidence of any viral transmission to the baby during pregnancy, no evidence that pregnant women are more susceptible to this virus. They do put pregnant women in their quote unquote vulnerable category, but they say that's just out of extreme caution. It's not that there's any evidence that pregnant women are more susceptible, but they do refer to the fact that viral illnesses, that obstetricians and midwives have long known that some pregnant women are more susceptible to viral illnesses in pregnancy. And so it may be that there is a small cohort that would be more susceptible. So in the interest of caution, that's why they're putting pregnant women in the vulnerable category.
Thank you. And we have a question out there, which I think is really useful, that just came in the chat, is we know in New York City, we often don't have private rooms. This may not be an issue if you're watching from elsewhere, but when you're recovering in the postpartum room, it's unusual to have your own postpartum room in New York, and most rooms are shared. Are we doing anything to reduce the amount of shared rooms for recovery, considering the coronavirus?
I have not heard anything about that. It's a question I have as well. I have heard, though, that my hospital is having all babies do rooming in. I don't know if they're not going to be using the nursery, but that was one of the things that I learned on Friday evening.
Okay, that's a great update to know about. Thank you. And one of the last questions, and then I think we'll shift to Dr. Capiola for now, is just, are there, what are the plans in the labor ward, on the maternity wards? Are there any planning situations or situations where we're imagining if there really is not enough room that we're going to need to move people to different hospitals or different locations? Is there anything that you're hearing or preparing for right now?
Sure. I've seen no I've heard nothing about anything like that. I've seen, I learned over the weekend that the governor has identified the Javits Center as a setting where corona patients will be cared for. So I think that there's an effort to create appropriate, ICU-like settings for these patients, as opposed to moving other patients out of the hospital.
Thank you. And another question came in that's probably good for both of you. Dr. Worth and then Dr. Capiola could segue off of it. Somebody writes in that they've heard that some hospitals are separating babies and moms or birthing parents if the birthing parent tests positive. Have you heard anything about this? Does it seem necessary? What is going on with that? And in what case would it be necessary, or why would we actually be separating a baby from the birthing parent if they're testing positive?
Sure. I had heard that too. And I believe, and I don't now remember actually where I heard that, but the issue is that if a mom is COVID positive, then that she would potentially, the baby would be separated at birth so that she would not expose the baby to the virus through her droplets. And it's an issue related as well to breastfeeding and whether you would in fact pump breast milk and have someone else feed the baby in that initial period. Of interest, the Royal College in England is not recommending that. So Dr. Capiola,
not recommending separation?
Not recommending separation in the guidelines I was just reading, in preparation for this.
Thank you. And I think we'll pass this. This is a good segue to Dr. Capiola. Why would somebody recommend that? Or if the birthing parent does test positive, how, and we talked about this last time, but I think it's really important to go through it again. How does transmission happen to the baby, or why and how are we protecting the baby from that transmission?
So from a breastfeeding standpoint, there are a couple of options. First of all, there's no transmission through the breast milk of COVID. It's not present. COVID is not present in the breast milk. So likely, if there is transmission, it's going to be via droplet and respiratory droplets from the mother to the baby while the mom is caring for or feeding the baby. So we would try to take all precautions for mom to do good hygiene, hand hygiene, perhaps wear a mask and breastfeed, and then transfer the baby, who would hopefully be able to room in, but at least 6 to 10 feet away from the mother in the room. I think that's more ideal. Although I've heard the same talk and I'm not sure where this is going to go at each hospital. I suspect they're all going to have a different plan. Another option would be for mom to clean, hand hygiene, wear a mask and pump, and then a healthy individual would care for the baby in between, do feedings with express breast milk in a bottle, and then also do in between baby care, as opposed to the sick mother. So that may be a little bit safer, but certainly breast milk is going to be the best thing for the baby. So because of antibody.
And if somebody has been breastfeeding the whole time, let's say, and they have a 6-week-old, and then the lactating parent becomes diagnosed with COVID-19, are they to keep breastfeeding?
I would encourage them to keep breastfeeding. The infant has already been exposed, and offering those antibodies is really going to be, through breast milk, is really going to be most protective for the baby. So that's what I would recommend to my own patients. I mean, hoping that there is another healthy adult to do the in-between care for the baby. But at least the feeding can be done by the mother.
That's a great point, that if the other parent is healthy or there's somebody else who's healthy who can help. Now, somebody actually did write into us and asked, well, what if both parents do become ill and are not able to care for the baby? What do you recommend?
Well, we hope that one of them is at least well enough to do the day-to-day care, because I don't even know the legality at this point with new New York State regulations with having someone else then come into the home to care for the baby. And that's a real gray zone here. Yeah. But hopefully whoever is better off can do the feeding, and mom can continue to express milk if she's not the feeding parent, or she can just directly breastfeed and be careful with hygiene.
Right. And so if a lot of people have questions about how to work with their pediatrician in this time. So if a baby were to present signs, or actually we'd like to know what are the possible signs that an infant would show if they were presenting signs of having this disease, is the recommendation to bring them into your office? What do you do if you think your baby might be sick?
So in a baby under 4 weeks of age, all babies with a fever certainly automatically have to go to the hospital. And that has always been the case prior to COVID. But if there are issues with poor feeding, extreme lethargy, jaundice, those are all reasons why a baby would need to be evaluated urgently, whether or not COVID is in the community. Fever is an emergency in that age group, no matter what. Up to 8 weeks, all babies need to be evaluated. But you would touch base with your own pediatrician about how best to do that.
Can you verify what is a fever? What degree are we talking?
So 100.4 Fahrenheit, which is 38 degrees Celsius, depending on what you prefer.
Okay.
And I would usually recommend a rectal temperature in that age group, because in that age group, accuracy of the temperature is extremely important. Past 2 months of age, I tell people it doesn't really matter. You use your judgment exactly to the degree or to the decimal point how accurate a measured temperature is. But under 8 weeks, please do a rectal if you're concerned about your child being ill.
And tell us a little bit about, at your practice, what is the protocol now this week, if, in terms of well visits, sick visits, just could you go over all of that and what people should be thinking about in terms of how they're minimizing visits and how you're doing telemedicine? How is that all working for you now that you've been doing it for about a week?
So we're basically seeing well children in the office. If there are some low-risk sick children to be seen, they would be seen after all of the well children have left the office. Every patient and caregiver who would be coming to the office is screened for COVID exposures, symptoms, et cetera, so that we can minimize and mitigate exposure in the office. We are doing the crucial early well visits. So the American Academy of Pediatrics came out with a statement this week that it is crucial, essential for children up to 4 years of age to come in for their routine checkups, because their growth and development needs to be monitored so closely. They need a good physical exam and they need to be vaccinated, because the last thing we need is, on top of a COVID epidemic, for there to then be a pertussis epidemic, because now there's a whole cohort of infants who have missed their opportunity for vaccination. So those early well visits are really crucial, and that's why we are prioritizing those and leaving the older children checkups to be more optional. People want to come in if they have concerns. We may do things via telemedicine in the older crowd. We're doing most sick visits through telemedicine as well, but those infants and young toddlers up to age 4 need to come in for their checkups. It's really important.
And for the telemedicine visits, what kind of things are you recommending that parents have at home? They should have a thermometer. Are there any medicines like acetaminophen, or what are you recommending that people have at home that you might guide them through? Scales also, we talked about that last week. Is that still the case? What are we looking at in terms of measuring baby's weight?
So we're doing newborns and still some weight checks at this point in our office, and some babies do need follow-up pretty closely if they're losing a lot of weight or if they're looking jaundiced. But if parents are uncomfortable and we feel that a baby's low risk, we'll guide them. We'll do some telemedicine if they have a way of weighing their baby somehow at home, and that would make them more comfortable, and we can be, fairly certain of the accuracy of the scale that's being used. I mean, we will work with people because we all understand the anxiety around this, and we want to keep everyone healthy.
Yeah, I was saying earlier today, we were just chatting that we'd heard that some lactation consultants have been using pastry scales with their clients, and that if they have, those are fairly accurate and that it can work. And so you would be open to somebody improvising with whatever scale?
Certainly, and also it helped us to be able to take a look at the baby. We would try to do that via telehealth, although photos of a jaundiced baby can be even more difficult to assess than even a baby in person, which isn't always so easy, even to an expert trained eye. But those early visits sometimes do need to happen, a few of them, just to make sure that a baby's doing well. Emergencies are still happening, not related to COVID, even in the time of a COVID pandemic.
Dr.
Oh, sorry, go ahead, Doctor.
Oh, could you just comment on what I've been hearing about not using ibuprofen? Obviously for babies, but I mean, I've heard this, and I didn't know if this applied also to, you know, any potentially patients that had fever and were sick.
Absolutely. So early on in the week, the WHO came out with a guideline about not using ibuprofen in patients with COVID due to some molecular level theoretical risks and some case reports of patients in Europe having complications taking ibuprofen while being infected with COVID. A few days later, though, the WHO came out and said they retracted that recommendation and now say you don't need to avoid ibuprofen in COVID cases. Now, this is always my spiel with patients. Fever is not a problem all by itself, other than in the under 8-week crowd. Fever is an important part of our body's immune system fighting a virus. We've all learned that COVID is sensitive to high temperatures. I mean, this is our body trying to make itself not conducive to growing more virus, okay? So this is our immune system active. So I always tell patients, don't look at the number of a child's fever, okay? We wanna make a child more comfortable. So if your child is 104 and you can just give a dose of Tylenol and bring that child down to 103.5, that's okay if the child feels a little bit better. The fever itself is not an emergency. It's more about how the child feels as the temperature comes down. I don't care if a child is 104 or 105, if the child is staying hydrated, if the child is responding well to a little bit of acetaminophen and feeling a little bit better, if there aren't signs of breathing distress. Those would all, of course, be reasons to touch base with your pediatrician. But making your child comfortable and not worrying about the absolute number, I think, is really good advice, especially in this time. And all of these questions, we have no good data yet about what's safe and what isn't. I mean, people are conjecturing in either direction from day to day, the World Health Organization. So I think touch base with your pediatrician, get good guidance.
Thank you.
And we'll update next week if there's more information.
So I'm going to give you a couple of questions that came in. For those of us with due dates approaching soon, how concerned should we be with our newborns catching COVID-19? Can infants withstand the virus?
So in general, infants and children have fared well with this virus overall. In the age groups under 20, there was a paper that came out this week and data from China of about 2,100 children with COVID. Now, for whatever reason, the under 1 year population in that study showed that there was a higher incidence of severe and complicated cases versus other age groups. That being said, some of these patients were presumed COVID cases. So the data is very complicated. They might not have even all had COVID. They might have also had COVID and something like RSV, which attacks infants in this age group as well. So it's a little more complicated to say, is COVID really more dangerous in that age group? I think it's too early to tell. But we all should keep that under 1 year age group extra protected, especially in the first 8 weeks of life, like we've already talked about a lot.
And what is your recommendation for healthy, asymptomatic grandparents, visitors, family members to come visit, the newborn? We have somebody who's due to give birth this week and is trying to figure out post-hospital visit plans. I know a lot of people had postpartum doulas that they had planned or baby nurses that they had planned, and everybody's kind of wondering, what is the protocol? But let's start first just with family members. What are you suggesting, saying?
So in general, I always tell people you have to think about risks. And you have to take, or not, a calculated risk with the number of people that would be coming to visit. So this is all before the new governmental guidelines that are being instituted in New York State as of tonight at 8 o'clock. In general, I say limit exposures, limit people visiting. And right now, we know that some people are asymptomatic and carry the virus very early on and right before they start to show symptoms. So I think to be even more cautious, especially with older people visiting, for their protection as well, I think is in order at this time. Was that clear?
Can I just,
Dr. Worth, please.
I've been thinking about this quite a lot because I have an immunosuppressed father who's 80 years old who had a kidney transplant. And so I've been reading these guidelines very carefully. And the governor said this weekend, and this is crystal clear that people over 70 should not leave the home, and that they should not leave the home, and that they, if somebody must come over, it should be only an immediate family member or someone who urgently needs help. And if that person comes over, they need to be screened before they come over for fever and flu-like symptoms. And then when they're there, the person over 70 and the visitor should both be wearing a mask and should be 6 feet apart. So it's hard to imagine, you know, it may be that during the peak of this, to protect our grandparents, that they're going to have to visit virtually. I mean,
That's right.
But that doesn't sound to me like there's any way for those grandparents to be coming over and visiting the newborn.
Yeah. No, it sounds like the grandparents and the same. We're saying, you know, we've been matching people to postpartum doulas for quite some time, and right now it's not mandated that you can go out anymore. Social distancing is quite mandated, and without any testing, that we don't have mass testing or an ability to test somebody, and so we are shifting to all postpartum support being virtual, which we all know is not the same, but seems to be necessary right now. And so, you know, again, we want to remind people that they can reach out for virtual support, that they can reach out for virtual mental health therapy at Boober and or wherever else. If you have a therapist that you haven't talked to in a long time, it might be time to reach out and just to know that you are not alone in feeling totally anxious and worried and concerned right now. I'm sure you've seen that in both of your patient populations who have a lot of questions and concerns and worries.
Yeah, I want to also give a shout out to an article that I read just a few hours ago in the New Yorker, in the current issue of the New Yorker by Atwal Gawand. I'll try to pull it up on my phone, but that essentially saying how to protect healthcare workers, because what I thought was so interesting about it was it talked about how in one of these other countries, initially all the doctors and nurses got sick, and then as soon as they changed sort of precautions, nobody got sick. And it essentially didn't even involve the N95 masks. It was really just the 6 feet of separation, being masked at all times with, and that it was, what am I trying to say? That it's not, at least in this article, and he's a respected surgeon and a, you know, Pulitzer Prize winning writer, that it was not brief interaction. It was actually prolonged contact with people that led to, especially in enclosed spaces without good airflow, that led to, you know, getting infected from other people. So I thought that article was very hopeful. I'm going to pull it up and show it on the screen.
Okay, great.
It's if you can see, it's this one.
Coronavirus from infecting healthcare workers.
Yeah, it's very, very interesting.
I'm writing that down. Infecting, and that is, was that the New Yorker?
New Yorker this week, the March 21 edition of the New Yorker.
Okay. And somebody writes, are you saying doulas should no longer attend your home in early labor? Somebody writes in. Yes, I think I, as the owner of a doula matching company, am unfortunately, and hate to say it, because you know, Boober has been 100% about in-person care. We never did virtual anything. And we have really pivoted 100% right now, or maybe that's just, we've done we've moved. We really need to keep everybody safe, and social distancing is the main tool that we seem to have. So right now we are recommending switching to virtual support in early labor to protect yourself and to protect the doula and their family, and yourself and in your family. And do you agree? I guess, Dr. Worth, I'll let you jump in on that from the more medical perspective.
Well, God willing, these are temporary emergency precautions that, you know, that this will pass and we'll go back to normal. I mean, I hope. I mean, I think this is just a very temporary, as we, you know, we need to learn more about this virus. We need to learn, you know, in the British guidelines I was talking about, they talk about, you know, when after you've had the disease and then you test negative. I mean, we're not even really in this country at that stage where we're talking about people getting over it and assuring that they're better and moving on. And is there any immunity? I mean, there's so many things we don't know. I mean, you know, we need treatments, we need a vaccine, we need knowledge about the virus. I think as soon as we have those things, I hope it'll be a lot less terrifying.
Thank you. And we had a few other questions actually about fertility, and we're going to wind up in a moment, but just several people asked, is this the time that I should, I don't know if you can speak to this or not, should I not be trying anymore? Should I stop? What is the risk, you know, if I were to get pregnant now and I'd be 6 weeks pregnant and 6 weeks from now when things may be worse? Do you have any thoughts on that?
Any thoughts on that? Well, you know, I there's never a perfect time to have a baby, right? And baby's our hope, baby's our life. You know, it's what, you know, we love our children so much. I guess personally, if I were planning pregnancy right now, this very minute, I might pause for a few weeks, because I think the best experts are saying that this is going to come and grow and pass. You know, there's always the talk about it coming back, but I might delay just a few weeks, 1 or 2 cycles, perhaps not longer than that, but 1 or 2 cycles to reassess, just a pause, a brief pause.
That's thank you. And there's one other thing that as we start to wrap up, I did want to address this time, because we talked about it last time. So anybody who didn't watch the first webinar, you can find it at getboober.com on the COVID-19 resources page. So you can just look for that. There's a tab for COVID-19 resources, and you can watch the first one where we talked a lot of the basics. And we also did talk about that many people are concerned and we're wondering, should they be thinking about a home birth at this point? Is that an option? You know, and we said last time we weren't sure that there were many home birth midwives who were still available. I have since reached out, and there are a very limited number of home birth midwives who may still be taking some clients who would be the right people. They'd have to connect and see if it is the right fit. If you are interested, you can certainly look at nyhomebirth.com if that is the right thing for you. And if you're somebody who had already explored home birth, and that's a question that you have. So I'm gonna just share that link in case, you know, people did have some questions. I see somebody here wrote in actually about, well, what about midwives and home births? Are they coming and socially distancing? And that question, I think that's the same as an OBGYN, and healthcare workers have sort of a different responsibility, and whether they can socially distance, but they can protect themselves and you in different ways, right?
Yep.
So anyway, any last things that you would both like to share with the community?
I'll start. I'll just say, you know, it's a week later, and it certainly, you know, Dr. Capiola and I and Jada, we're all here to help you however we possibly can. We'll share everything we know. We're following it obsessively, reading everything we can find, and just so eager for everyone to be healthy and safe, and we'll support you whatever you need or want.
Thank you. Dr. Capiola?
Please reach out about the health of your children. Honestly, I've been a therapist also this week to many parents and patients dealing with the stress of this. So reach out. We're here for you too, and we can all support each other.
Yeah, we are all here for you, and anything that you need from us, just please reach out. Shoot us an email at Boober. I'm Jada, Jada at getboober.com, and you can reach me that way, and I will find resources for you if I don't have them myself. We will be out there looking for that for you. So thank you so much to everyone. Have a good rest of the evening, and hopefully we will talk with Dr. Worth and Dr. Capiola again soon, and then hopefully not again for quite a long time. So thank you.
Thank you.
Bye. Thank you.